Hey, Paul, I'm excited to tell you that we are launching a Curbsiders Patreon. Have you heard about this?
I did because I work with you, but tell me more about it.
All right, Paul. Well, we want to be able to keep offering this great free content, and we're doing things like upgrading our website. We offer transcripts now for episodes, recording new seasons of our miniseries, Teach and Addiction Medicine. The digest is growing its staff. And Paul, now we're on video. People can see us as we're talking right here.
What a treat for our listeners.
That's right. So with Cashlack admitting privileges, they're going to get all episodes ad-free. That's the whole back catalog, plus future episodes. And twice monthly, there's going to be bonus episodes where me and you recap a show and answer some listener questions. So people should sign up today at patreon.com/curbsiders. And you get a whole lot more of Paul, America's PCP.
Welcome back to the Curbsiders Addiction Med, which, of course, you know by now, is our mini-series on substance use disorders. I'm Dr. Carolyn Chan, and I'm joined by my co-host, Dr. Sean Cohen. On tonight's episode, we are really stoked. This is just a phenomenal episode. We're going to chat all about caring for individuals with substance use disorders who have criminal legal involvement. Before we get started, Sean, will you just remind everybody, what do we do on this show?
As always, I would love to remind everybody, we are the Addiction Medicine Podcast, and we use expert interviews with people that we've learned a ton from, people that we admire, to really demystify common addiction med topics, reduce stigma, and inspire listeners to become fierce advocates for all individuals who use substances. And as a reminder, most of our episodes are available for free CME credit through VCU Health CE for all health professionals at curbsiders.vcuhealth.org. All you have to do is create an account.
And a very special thanks to the American College of Academic Addiction Medicine, also known as ACAM, who has helped partner with us to support this series. ACAM is the proud home for addiction medicine faculty and trainees, and they are dedicated to training and supporting the next generation of academic addiction medicine leaders. You can learn more at their website, acam.org. And whether you're an addiction medicine doc preparing for boards or a physician in self-practice just looking to learn more about the addiction field, ACAM offers several self-study products that can help meet your needs. The professional practice bundle includes access to 86 self-assessment modules that provide CME as well as 46 didactic lecture recordings. ACAM's board prep bundle also offers access to the 46 didactic lecture recordings along with its nearly 200-item question bank, as well as an addiction e-practice test. So to check these out, be sure to visit their website at acam.org.
And I'll say I've done a lot of that stuff previously during fellowship, and they are amazing. Some of the didactics are super great, so give it a go. So you will not be PO'd. You get it? Because it's like parole officer. PO'd about our conversation with Dr. Puglisi.
And it fits with your whole expletives, that we talked about the last episode we did together.
So Dr. Puglisi is an internist and addiction med specialist. Her clinical care, education, and research are really focused on improving the health and well-being of people impacted by mass incarceration. She directs a transitions clinic in New Haven and a statewide network of similar programs, which are part of the national network, the Transitions Clinic Network, that she gets to talk a little bit about more, and honestly is amazing, which is focused on addressing the health needs of people returning to the community after incarceration by hiring previously incarcerated community health workers into health systems. And she is an assistant professor of medicine at Yale School of Medicine. She teaches us really about the impact of mass incarceration, how to address that in a clinical encounter, and how to have a trauma-informed conversation, really focusing on kind of the historical aspects that you can really help someone with. She teaches us a little bit about how to advocate for people with their probation or parole officers if they're interested in that, and how to advocate in the hospital setting. And I think really emphasizes the point that there are a ton of barriers for people who are recently incarcerated towards getting back to life and getting back to kind of a functional life that are really, really difficult to surmount. And so the importance of really knowing your resources, having multidisciplinary care to really help people as much as you can. And so without further ado, let's get to this crazy great episode.
Lisa, thank you so much for joining us on the show today.
Thank you for having me. I'm delighted to be here and really excited.
And as always, Sean has written an incredible case from Cashlack Memorial. Sean, why don't you tell us our case for today?
We'll start with Mr. C, who's a 42-year-old man. He has a history of opioid use disorder, and he is not currently on treatment with medications for opioid use disorder. He also has hypertension and diabetes, and he tells us that he was recently released from incarceration 1 month ago, and he's presenting to establish primary care. There's really no other records in the EMR about him, and his records while incarcerated are not available to you at this point. And so I'm wondering kind of when you're first seeing a patient in clinic that has a history of some sort of kind of criminal legal involvement, what's your approach to taking a history? Kind of how do you ask the questions, and why does it matter that we ask these questions?
First of all, this sounds really typical. I tend to never have any medical records when people show up. So this is a really spot on case. I think that before we jump into like exactly what we ask in the history, I like to zoom out and frame it around why we ask these things in the history, like what we ought to know. And you can't talk about that without framing this issue in the social context of mass incarceration, which is really the outcome of decades of policies, intentional policies that put in place punishment for people who had drug use, substance use disorders, poverty, and really put in place very long sentences for the past really 50 years. We've seen this. And then policies continued to enact punishment even after the sentence was served, as affected through the stigma of a criminal record and how that impacts access to many social policies and structures in the social fabric post-release. So really, this affects now like 70 to 100 million Americans have a criminal record. And I think that's important to highlight too, because like you will see these patients. This is an American problem. But it's also really important to highlight that it disproportionately and really intentionally impacts more racialized, minoritized populations, Black and Latinx folks, Indigenous people, and affects people over their entire life course, affects families and entire communities. So the history can go actually really broad. Tonight we'll focus on the individual history. And I like to start by trying to, let me start with this. This is a personal opinion. There's a lot of the jury's still out on whether we should screen everybody for incarceration history. There's healthy debate around it. I think the fear of doing that is further stigmatizing people in the electronic health record, et cetera, which we know is a very real phenomenon. But I think if the science develops more and we can find thoughtful ways to do it, it creates an opportunity to really address some very serious potential health harms and to improve health overall after release. And ultimately, hopefully, to help that person stay healthy in the community, really where they belong. So I ask a number of questions, but I start with a trauma-informed approach, meaning putting power back in the person's hands, right, and asking permission to go there. So let's say somebody's screened positive or they come to me and say, I just came home from prison. I would say something like, is it okay with you if we talk a little bit more about that? I'd love to learn more about your experience being incarcerated, and I hope that it can help me, help us identify some things we can take care of together, or help me get a better sense of who you are. There's many ways you can frame it, but the concept is in a trauma-informed way where you're asking permission to go there. And then there's a number of things you can address with people. So just like you do with taking a thoughtful addiction history, you're trying to get that picture. Like, who is this person? What were the patterns of their use? How frequent? Over what years? Did it start all of a sudden, or did it escalate crescendo over the years? What is after the death of a loved one? Like, what is it, right? And you want to walk away from that encounter where you're talking about incarceration history, getting a snapshot of how this has affected this person's life. A couple key components. One is age at first incarceration. So was this I met somebody today. He went to prison for the first time when he was 14. to a juvenile facility. That impacts people's entire life course, and you need to really address what even happened to them at that age sometimes and really dig in there over time. But it can give you a snapshot, right? This like image of like how this has impacted someone's life. So age at first incarceration, and then the dose and the density. So like how much of this place, of this institution, have they been exposed to over their life course? Is it 15 incarcerations in jail, always for less than 6 months, but they can never stay out for longer than 6 months? Right? That's one phenotype. I see many people who went in when they were 17 and served 35 years. That's a whole different phenotype. Their risks after release are very different. So is their social network. So is their understanding of how to function in the digital age, right? Like the things they may need are just so different. When did they get out? How long has it been? Was it 2 days ago? Or was it 6 months ago or a year ago? Those can also be very telling. The risks immediately after release are very different than the risks down the road. And then are they under any type of what's called community supervision, which is essentially ongoing forms of control through probation or parole? Because that might help you understand some of their limitations, some of their barriers, some of the other forces acting on their decisions, and can help you just have more informed conversations with them. And then I also like to understand how long someone's been in the community successfully. Like I said, for what that past example, like, can they kind of never stay out for more than a year? Or I've had people who have done 2 really long bids, but in between were out for like 10 years where they started a family, right? And then you can identify, like you do with substance use, like what was going well then? What worked for you in those 10 years that helped you stay home and be successful and, et cetera. So I think it's actually quite analogous, as we're talking about it now, it occurs to me, to taking a substance use history.
I love it. So just to summarize, you sort of start with this trauma-informed approach. So asking for permission. Hey, is it okay if I ask you just a couple more questions about your experiences, just because I want to get to know you better, and giving them the opportunity and the power to sort of like accept or say maybe not today, followed by, I like your age, dose, density.
One of the other things I wonder is like that first visit when you're seeing someone and getting some of this history is like being in the medical setting, which I think is often, I think in some instances it can feel carceral. That's maybe more the hospital, but it's often like not a place where people aren't comfortable. Like, are there ways where other ways that you can like really work to gain trust early on, or things that you really make sure you really want to get that, like information you want to get that first visit?
Yeah, I think at the provider level, there's some things you can do. The same way you would build trust with anybody, right? Like creating a safe environment, letting somebody sit near the door if they choose to, so that they don't feel trapped in the room, giving them, again, all trauma-informed stuff, so all the power back in them. Asking them also, not framing it all around the negative, but framing it around the positive. So what do you love? What are you good at? What was your job inside? Did you get any training inside? Did you do school inside? I have people come home who have completed a bachelor's inside and are working towards a master's. That is like total respect, right? Like, I'm like, you did that inside? Like, that's incredible. Talk to me about what you love. What are you going to do with this? And suddenly you're just connecting with somebody on a very human level, and they're not a criminal, right? They're somebody who's taken college classes and is really interested in anthropology. So I think exploring their experience isn't just always focused on the negative, but what are their assets coming out of that experience as well? For instance, you can then utilize that later in your relationship. So I have patients who then have a very hard time in the halfway house or with their probation officer. Oh my God, they're driving me nuts. Like, I can't take it. Right? And I'm like, Thank you for sharing that. And I hear you. I would be frustrated too. And I just want to remind you of something. Like, you can outlast anyone. You just served 30 years in prison and came out alive, which is not easily done. I think that you can kind of use some of the conversation and the knowledge you gain in that conversation to help build trust, rapport, respect, and just let somebody be. They've been called a number inside forever. And so letting somebody be seen as a person and focusing on their positives despite that experience, I think really gains trust. And then you guys both know me. I'm a real straight shooter, but I became that way with intention. I wasn't always like that. I grew up my whole life as a real pleaser, but I became just a real straight shooter when I started focusing on this work, because people can sense somebody who's phony from a mile away, right? So I try to be real practical. Listen, you have like 10 health problems. You and I can probably address 2 today. You pick which 2, and I'll, maybe we can address 3. You pick 2, I'll pick 1. And let's try to focus there. And then I'll just have you come back soon. Like, I can't actually get more done with you in a meaningful way today. And people respect that and understand it. I think the other thing that we can do is, in the hospital setting especially, is really address the presence of law enforcement. So I've started talking to you as a generalist in the primary care setting, but I also work in the hospital setting, as many people do. And one real way to garner trust, I think, is to address that there's a stranger in the room and who has no personal relationship to the person. And it's actually a HIPAA violation for them to hear any personal health information, even though in many instances they may say HIPAA doesn't apply to them. Well, it applies to me, like I have a medical license, which is to uphold patient privacy and a code of ethics. And so you're not always going to be successful, but addressing the fact that there's a stranger in the room and artfully trying to get that person out of the room. I have had people be like, whoa, you're suddenly like, I think you gain mega trust points when they're like, thank you for acknowledging that there was someone I don't know standing next to me as you were, about to undress me or something, right? Like, I don't care that person has to get undressed in front of an officer in the prison or in the jail. That's not happening on my watch if I can help it. And I think that garners a lot of trust as well, not pretending it's normal.
And through all your amazing tips, you're really successful. And, Mr. C, he trusts you. He tells you a little bit more about his background, that he's been in and out of the carceral system, unfortunately, for most of his adult life. And his longest period in the community was about 2 years. And most of his time incarcerated relates to substance use. So while incarcerated, he's unfortunately been subjected to solitary confinement twice, the longest period for about a week. So when you hear a little bit more about him, and you alluded to this earlier, are there any specific health risks you think about around specific experiences within the criminal legal system?
Yeah, there's really specific and really grave health consequences associated with incarceration itself, and also specifically recent release from incarceration. So you mentioned that this patient has been exposed to solitary confinement. In some places that's called restrictive housing or segregated housing. There are many euphemisms for what it is, but it usually means really extreme kind of social interaction deprivation and being in a cell 23 hours a day. And that has been associated in studies with an increased mortality after release from incarceration, specifically due to suicide and overdose in those first 2 weeks after release. So just identifying that, these are things that we can address, right? Like, we can address and prevent suicide and overdose. We know how to try to do that. Right? And so screening and just saying, geez, you were in solitary confinement. When was that most recent? differently. And he might say, oh, that was 15 years ago when I went in and I was rowdy and, went to SEG. And then last 10 years I've been, working inside and done fine. Okay, not a huge risk, right? Sometimes when you say how long were you exposed to it, I've heard 2 years. And then I might say, whoa, just acknowledge, right? Like, wow, that's a really long time. Can we talk a little bit about how that might have impacted you? And you hear all sorts of things. Some people say, I preferred being in there. It was better than being in general pop and, I preferred the quiet. Other people are like, I was not right and I have not been right since then. And, it's everywhere in between that gradation of experiences. So you can't just assume. And so it allows you to address how it might have affected them mentally inside, but also now that they've been released. Someone who's released really proximal to the confinement, solitary confinement, can often, that's like who's at most risk. And it can be with, depressed mood, PTSD type symptoms, real kind of hyperexcitability, like difficult time dealing with noises, people around them. And so you get to address that. Whether it's offering access to counselor, behavioral health services, medications for PTSD and anxiety, screening for serious depression and suicidal ideation, and then educating and informing on the overdose risk and just talking about the possibility of a relapse. Additionally, though, it's not just solitary confinement which puts people at risk. It's this total transition from one health system to another, along with all the pressures that come with release, the social pressures, the pressures from probation and parole. And these are populations of people who, during incarceration, and even those who are on probation have never been incarcerated, have higher rates of respiratory ailments like asthma, COPD, heart conditions, uncontrolled hypertension, and then infectious illnesses like hepatitis B, C, HIV, sexually transmitted infections, and then, of course, the substance use disorders, mental illness, and don't forget nicotine use disorder, like really, really high rates of return to smoking after release.
Yeah, so I'm hearing from you is first of all, is that prison, jail itself, like incarceration itself can be a big risk factor for a whole host of things. But it's really that it's like talking to people and getting the history can help inform what you're thinking of, what you're worried about proximally. And so like specific risk factors like being in solitary, especially like just before release, is something where you're going to really want to think about mental health, PTSD, risk of suicide. But really any incarceration, you're going to be wanting to think about like return to substance use, risks of heart disease and infectious diseases, higher risks of asthma and other respiratory diseases, and just be kind of have your ears up for thinking about like, how do I screen for these people, taking symptoms and complaints very seriously, having low thresholds to kind of start working some things up and helping them.
Yeah. And one other thing, Sean, is that we underappreciate that we don't always understand like when the person got diagnosed with their chronic illness and what their health literacy and self-efficacy is like. And so someone who had diabetes before they were ever incarcerated, took insulin for years, got incarcerated, and then came home may have a labile A1C and may need supplies and stuff like that. But that's very different than somebody who was diagnosed inside, let's say, and has never self-injected insulin, these sorts of things. And the same thing, this kind of difference can also be seen with substance use disorders, where somebody who has been on MOUD, let's say, for decades and then went in, had different experiences and comes out is very different than somebody who may have started it for the first time during an incarceration, let's say. So understanding like the treatments for their medical conditions and what those were like pre and during incarceration, I think can also be really telling.
And I think that's a pretty good transition to kind of the next point in our case where, so Mr. C tells you that he was on buprenorphine once before, but when he was incarcerated, not per his preference, but it was abruptly stopped. And he's now afraid to go on it again because he's really worried that if, God forbid, he's incarcerated again, it's the same thing is going to happen. And so most of his periods when he's been able to not use opioids are when he's been incarcerated. Often when he's out, he's unable to find work due to legal history, gets reconnected into dealing, which is what's led to most of his arrests, because that's really the only way where he can really make money and support himself and support some of his family. And he's worried about getting on MOUD. Is it going to mean something for probation? Is it going to come up on drug screens? How's his PO going to react? Are there any conversations or points you make specifically about meds for opioid use disorder for people that were recently released from incarceration?
Yeah, it's complicated. So I really start by trying to understand, just like you said, past experiences. So what have your experiences with MOUD been like, and how have those experiences been touched in any way by the criminal legal system? For instance, there is an age-old story, and this is all because of really a total deficit in availability of MOUD in carceral facilities until the last 10, 7, 5 years, and still it's not available in most facilities. But so this has created a legacy of people who were on methadone in the community, got incarcerated, and had forced withdrawal. And, you can't have taken care of anyone who's been on methadone really and had any criminal legal system exposure and not heard that story before. We have all heard that story. And it's awful. And people are often like, never again, right? And so you have to acknowledge, like, I understand why you're saying never again. That sounds awful. And so while we may try to explore, like, really never again, like, would you maybe, like, are there circumstances under which you might consider it? Or like, hey, there's other stuff available. Let's just respect the fact that you are not trying methadone again and just go a different route, right? So I think understanding the way the criminal legal system has intersected with their past treatment experiences is just super important. There is now going to be more and more a news story of people who were started for the first time during incarceration, as there's expansion of access to MOUD for incarcerated people. This will be a new story people hear about and a new opportunity to understand what that person's treatment goals are. Just because somebody started MOUD inside, as research shows, that doesn't mean they ever intended to continue it outside. They may have started it inside just so they didn't have to withdraw in there, or just to make the experience go by better, without cravings or symptoms. And they may have always had every intention to stop it upon release. And that's okay. But it's something to talk about, right? And to talk about risks, and then bring in harm reduction, and right, all that good stuff that you spoke about with Kim Soo on a previous episode. Likewise, they may have decided not to start in there because they didn't want to be labeled inside or have everybody know what their issues were. Like, there are facilities where it's like, methadone line, and it's not subtle, right? So some people will just say, like, no thanks. But just because they weren't on treatment inside doesn't mean they're totally opposed to treatment. So they may be open to treatment on the outside. So I think really understanding their goals, and then community supervision sometimes very much impacts these goals. So they might say, I've been home for a month, there was fentanyl in my urine twice, my probation officer is like on me and is going to send me back unless I get into a program. And you might say, well, I don't think you need an inpatient program, but would you consider starting methadone or buprenorphine? There's options here. And so sometimes these external forces are operating on their decision making, and acknowledging the role that plays, I think, can be helpful for your own understanding of what they're dealing with and for creating a therapeutic alliance where you say, okay, I get that we can get you into treatment too, but would you also consider, like, I don't think that you have to come off of this right when you get off of probation. Like, would you consider opening your mind to staying on this for these reasons for a longer amount of time? And then every single person, obviously, really has to be educated on overdose risk, on the poison drug supply, especially if they were in for a long time. Most people have heard about this, but really just providing an opportunity to answer questions about it that they may have. I heard it's in the pressed pills too. Is that true? Yes. Right. But just to have that conversation. But those are some of the things that I think about when thinking through MOUD for somebody coming home.
I think too, to your point of the overdose risk we know is just really high sort of in the immediate period after folks are sort of coming home. And I think particularly for folks who sort of like two phenotypes, sort of, folks who maybe were in custody or incarcerated for 6 months and were coming out versus those who were incarcerated, for like a decade and coming out, but still had that diagnosis of opioid use disorder. Would you consider, if they were interested in it, would you consider restarting and offering it in both these folks, and how would it impact your dosages at all?
It does, and I do. I always do. I always consider that and bring it up as an option. So just because the DSM-5 has the criteria as having had meeting these criteria within the last 12 months, like that goes out the door when someone's been in prison. So I don't care if you had those issues within the last 12 months. If you've used heroin every single time after you've ever come home from jail or prison, what's to make me think this time's going to be any different, right? And so I say that. I had a gentleman come home who was in his 50s, multiple medical problems, extensive medical problems. And he was interested in, a wheelchair, the right knee brace, the right getting on a water pill, those things for his comfort. And then when we delved a little bit into the heroin use and how he had never, ever been in the community and not used, it provided an opportunity to shift the conversation. And I was just like, I got to be straight with you. Like, I'm worried. Are you worried? Are you worried about this? And once we created that space for him to even go there, he was like, it is a little bit on my mind already. I'm just trying to not think about it. And then that opens a door, right? I was like, well, I think it's going to get louder in your head. I think the pull will only get stronger the longer time you're out, the more people you run into, et cetera. Would you consider starting a medicine to help calm those cravings so that we can take care of your health issues, so that you can engage, with your probation officer, et cetera. And he had said yes. I sometimes, would start somebody on 2 milligrams BID. Because I've had people tell me if they've been in for long enough and have a low enough tolerance, whoa, it gave me a little bit of a high feeling at first. And so I say you might feel a little something, but just start with 2 milligrams twice a day, get used to it, and come back and see me in a week. Because the immediate risk of return to use is not, it's there, but let's say this person's in a halfway house. It may not be as prominent, although certainly there is active substance use in halfway houses, depending. But you can kind of get a feel for that. If the person's my roommate's using, this is not good, then you might start at 2 BID for a couple of days, 4 BID for a couple of days, and by the end of the week, you're at 8 BID, a treatment dose, right? Therapeutic dose. But I think that that's the art part a little bit, and you can kind of play it with the patient as you see it, and have them guide it. You're checking in maybe in a couple days. How's it going on the 2? Like, you feel all right? And some people are like, I feel so weird. I don't want to do this anymore. And then I say, let's get off it, totally do a washout. And now would you consider, injectable naltrexone or something, right? Like, there's other options. If they don't want methadone, didn't like Bu. And so the doses can be different. You do have to acknowledge that this is not the typical person we're seeing now with active use, where you're trying to get them into treatment while they're actively using. It's the total opposite.
Totally. Like, there's usually this loss of tolerance, and
Yeah.
and even with patients, like patients I told you, right? I do ask, like, were you using while you're, on the inside? Because there is access to that too. And even if they're like, yeah, I think I have my same tolerance, I still am a little cautious, just because it's probably still not to that amount of use like they were using before they
definitely.
came in.
Yeah. And it's okay. It's okay to talk about using inside too. And I say to people, I'm not writing this down anywhere, but let's talk about whether someone say, I haven't used in 15 years. Well, you've been incarcerated for 15 years, right? But also I'm like, well, I know that stuff is on the inside. Like, talk to me about what you used inside. And someone will say, oh, I tried Suboxone once or twice, but I never really rolled with it after that. Okay, right? But it does give you a sense, and it opens that door to talk about it in a safe way.
And I should follow up with that point, though. I should say, I don't think we asked this. Do you, going back to the history, do you document this history?
So a couple thoughts there. Again, and this is just the Lisa Puglisi approach. But number one, in terms of why they were incarcerated, I, across the board, say to people, I don't need to know why you were incarcerated. I'm your doctor. I'm not a lawyer, a judge, a probation officer. But can you help me understand the sorts of things that get you incarcerated? Because that's something you and I might be able to work on together. So I don't need to know the exact details, and you don't have to tell me. Sometimes I'll educate people, like, you don't need to tell any provider, especially if they ask you. You can say no thanks. But what sorts of things? And then sometimes people are like, what do you mean? And I'm like, is it stuff you do to make money to support yourself? Is it substance use related, mental health related, not related to any of those things? And that can just open that door. And then I say to people, I'm not writing any of this down. And many people just come out, they are so used to having to talk about it that they'll just come out and tell you what it was. And then I say, thanks for sharing that. I'm not writing that in your medical record, just so you know. I write little notes. My what used to be as a resident, like this long prose, has become like, hieroglyphics. I might write like just home, 12 years, Walter Brooks halfway house, out for 2 days, served 25 total. 6, 5, 4, 3, and then just write a little pattern to myself to remember, or not write that at all and just kind of memorize it. But I write very little, and I'm open with patients telling them, I am not writing this in your medical record. And then I will say, if I do start typing, I'll say, I'm just taking notes about what you're telling me about your family so I don't forget. So I'll be real specific about what I'm writing, because many people even may not have even necessarily had exposure to an electronic health record before. And so it provides an opportunity to educate about what the heck are you typing on that computer, while also really kind of teaching them self-advocacy around, like, you don't need to tell this to anybody else who asks you in the health setting.
I think that's really helpful. So what I'm hearing is, like, first of all, is you don't have to write everything down that you get. It's like the stuff that's going to be, you can ask the questions in a way that you don't have to get the whole history that someone might not need to talk about, or things you honestly don't need to know, but write down the things that'll help you remind kind of big picture stuff in terms of what are the things that are going to lead to health risks, and then like life stuff in terms of like, how do you get to know this person a little bit better, and kind of narrating what you're doing a little bit to both earn trust and to kind of do some education and self-advocacy too.
And I'll say, like, we don't even fully understand often how what we record spirals and negatively impacts people. If there were something I was seriously concerned about, I'm learning new information that's putting anybody at immediate risk. Of course, that's a whole different, pathway to go down. But by and large, very little needs to be documented, in my opinion.
And I think the framing I also really like about thinking about how your documentation can add to stigma and impact subsequent care, and essentially avoiding things that have literally no positive impact and adding to the chart and can only have negative impact. We've talked about it a little bit and haven't really gotten into the definitions, but can you give us a little bit of a brief overview of the difference of probation and parole? And I think a little bit about, like, as physicians who are trying to care for people who have a probation officer or a parole officer, like, how do we interact with them to help people sometimes and to kind of get a better outcome for them?
Yeah, so probation is a form of community supervision, quote unquote supervision, but you're essentially under control. That can either be an alternative to a sentence. So somebody is found guilty of a crime, and then either they do probation time in the living in the community, but having to check in with a probation officer and having certain stipulations instead of being incarcerated, or it can be in addition to. So they get some incarceration time and then probation time that follows. So ongoing supervision, monitoring after release that comes along with many stipulations. Parole is when somebody serves the remainder of their sentence in the community. So they have been found guilty, have received some sort of sentence, 20 years, and then when a board of pardons and parole meets, they decide that person has met certain goalposts to be released early, but they are still serving out an incarceration sentence while living in the community. That impacts us by just understanding that that's stricter usually. Like, you do one thing wrong and you're back in. There's more of that risk of being swooped back in. And then your second part of the question was how to interact with probation and parole officers. So I do it always only with permission. So you say to the person, is there anything you would want me to call your probation or parole officer over? I will never answer their questions without your permission and without a release of information if they were to reach out to me. But if there's things that you want me to advocate for you, on behalf of you with them, I'm open to that, and you just let me know. And sometimes people are like, no need to talk to them. No problem. Other times somebody has had a urine toxicology that has some substance in it, and then there's a conversation about what to do. And we have many times, kind of with permission, reached out and then updated the officer on our medical plan and, how it very well may address the issue or why this wasn't an issue. I repeated it with a confirmation. There was nothing, And so I think you can actually play quite a role of advocacy with people's permission, and it's not successful all of the time, but I can think of a number of instances, either writing letters or with direct phone calls, where you can really advocate to change the course of somebody's supervision, quote unquote, experience.
And as you have alluded to, it's just really challenging to transition home. So what are resources that we can look specifically and refer our patients who have this experience to?
Yeah. So the barriers that people face after release are countless. There is the American Bar Association keeps a list of all the collateral consequences of incarceration, and it's in the tens of thousands. These are usually, though, hyper-local. So in every community, they're different. Where can you not get a barber's license if you have a criminal history? Where can you not live in certain places or federally funded places if you have a criminal record? Access to food stamps, like I said, professional licenses, IDs, jobs, etc. Access to food, housing. So I think recognizing that there are just so many, every person's may face different barriers. Some may face none. They might go right back into a family that's been waiting for them, has everything set up, right? Like, so it really can run the gamut, but by and large, there are a number of barriers people face. And this is where you just have to like really recognize, well, I think we should recognize this the whole way through, but we can't do this alone. Like you as the provider, you're just not fixing that stuff. You can't. It's not built to be fixed by you. And so this is where understanding your community really comes into play. Like there are in many communities across the country, lots of grassroots organizing of previously incarcerated people who are building organizations specifically to help people come home. So it's like finding it, Googling it, meeting with them, chatting with them, just knowing where they are so you could refer somebody there. But there are many assets and communities that are specifically coming up just to help people coming home. And then this is where in a clinic you can rely also on social workers. You know, all of my work is focused on work with community health workers. So you need other care team members to be a part of the plan often when it comes to addressing these collateral consequences. But I think as the provider, we can inform ourselves about what's available in our own communities. And then really expand the potential of our teams to make connections.
There are people that are really invested in trying to make this really broken. I mean, thousands of barriers is just like mind-boggling to me still, even though I knew the system was really messed up and shitty, to be honest. But like that there are people invested in trying to make this broken system better and like knowing your local resources, relying on hopefully your amazing team in your clinic and really trying to like wrap around and help this person and all of their needs and everything.
Yeah, this is a problem that's been going on now for 5 decades. So, there were people trying to do important work in this arena way before we came around. And so just identifying who they are in your community and connecting with them, I think, is really key.
Great. And let's jump actually to our last case of the day. So we're going to say, as we know, Lisa, you're truly an internist. So now you're rotating in the hospital and your team has admitted a patient, Mr. A, 20-year-old with opioid use disorder on buprenorphine 8 milligrams twice a day, who is currently in police custody. And when you walk in, you see he's handcuffed to the bed, his right wrist, left ankle, and there's an officer at his bedside. I need to touch about this briefly, but it may be a good time if you would be able to just summarize how do you interact with the officer while you're taking care of the patient in the hospital?
Yeah, I start by recognizing that this officer is somebody who needs to keep a job and usually often just a regular old person from the community. In many communities, these are the best job opportunities you can get. They're stable job opportunities with a good pension. And so I tried to come at it from that space of saying like, this guy's just, or woman is just here to do their job today. And so then I just appeal to their humanity and kind of try to slip it in a little. Hey, good afternoon. How you do? I'm making chit chat a little. And then I start talking to the patient a tiny bit, not about anything personal. How you feeling? This sort of thing. And then I say often to the officer, you know what? I need to get into more HIPAA protected information right now and an exam. Would it be okay with you if I just ask you to step outside the room? Or can I ask you just to step outside the room for some privacy? And then I won't be more than 5 minutes. I'll get, something like that. Because it's not often that you need tons of time. You just need some time to get some private information and a physical exam done in privacy as well. So I try to appeal to their own humanity. And then often I try to appeal to the shackles as well. That's a whole nother talk. But I think that us continuing to ask and try to get the shackles off, especially when there's an officer already in the room, is an important effort. Yeah,
I mean, I think that's great in terms of like acknowledging that everybody in the room is a human being is always probably a good place to start, and then kind of slowly easing your way into asking them for some privacy. I feel like it becomes this thing that we just accept, like this is normal, that someone else is in the room or that they have cuffs on, or when we really should be like questioning, like, why is this necessary? Especially when you're trying to get, it's history that is often stigmatized and criminalized, right? Like a substance use history where like, who's going to want to talk about what substances they were using in front of a police officer in the room? Like almost nobody. So like to get a real history, you need to ask them to leave. But are there questions that, in terms of like when someone's like in custody while they're in the hospital, are there questions that you ask in terms of like, where is the next place they're going? Like jail, prison, lockup, and how that affects, particularly, I think with, as you were saying, like meds for opiate use disorder aren't available everywhere, and how that changes kind of your calculus a little bit.
Yeah, it's critical to understand. We can't be practicing addiction medicine in a vacuum. You know, if you have a local jail that has no MOUD, you starting the person on methadone may feel, heroic. But like, what's the plan then when they're suddenly whisked back to the jail in 2 days? Within reason, maybe they needed a little bit to make it through the day, but you understand what I'm saying. That's not that can't be your treatment plan. That's not available to them where they're going. So number one is understanding what sort of facility they're going to after and how long they anticipate they may be there. Somebody may know very well, I have 5 more years of my sentence. Or they may have just been arrested and they know they're going to get bailed out. They're just going to be going back to the police station to lock up, and then their mom's bailing them out. That's very different in terms of what your treatment plan can be. And it ought to be impacting our treatment decisions. And then understanding what treatment options are available to people in those spaces. And this is changing all the time right now. Like not long ago, you couldn't get any controlled substance in our police lockup. And then just 2 weeks ago, I learned that I could start somebody on buprenorphine and that they would be dosed within the lockup and would be sent home with the medicine. Now, do I think it will happen exactly as that was presented to me? Likely not. But I just want to highlight that these treatment options are really in flux and continuing to grow as they ought to and as we need to be advocating for them to do. And so each time, even though I've been doing this for a decade now, I'm continuing to ask the officer. And then you're engaging them a little bit, right? Like, again, this is somebody law enforcement is like militaristic in its organization. And so this is someone whose boss told them they had to do this, right? Like that's what they're doing, is following the order from the boss. But then I kind of empower them a little bit. Oh, can you help me understand what's available in the facility? Or can you help me understand what's going on in police lockup these days? Then they're engaged a little bit, and then you can ask them, back to the other example, to step outside the room then. But I do think it's important and impacts treatment. As an example, in a hospitalized patient like this gentleman, if he's going to jail and anticipates he might be there for a couple weeks to a month or something on that order, and they do not have bupe available, you may consider injectable bupe, right? Because he'll be kind of covered for like a month. And then if he stays longer than that, at least it would be a relatively slow taper off, not sudden. And it might be slightly more humane and tolerable. And you tell the person, do you want to consider this? It'll hold you for 4 weeks or so. And then I think you'll start to feel a little something as you taper off. But I think it would be better than just stopping your meds cold turkey and going in. And some people will say, just take me off. I don't even want to deal with that. Or others are like, please, like I just can't go there and feel sick right now.
Before you even create a plan, just sort out what are the options. And then you sort of have to be creative and think about what is realistic. Because I agree, like, you can't start somebody on methadone, get them up to 80 milligrams, and then they don't have access to it. It's just, that's not humane. It's not a realistic plan.
Agree.
I mean, that kind of touches on it too, of like, is there, and this is a question I have for other issues too, but like, is there any way to make sure if someone is, say, like going to jail and they know they're going to be there for just a month or something like that, to make sure that they are able to follow up? Like, say you start them on bupe and they're able to, like, does jail always get them an appointment? Are you just going to assume that there's no chance in hell that they're going to wind up with an appointment and have to figure out another way to get them reconnected with care? Do you have like thoughts on that?
Yeah, it's a lot of like contingency planning, because you don't know what's going to happen and they don't know what's going to happen. So this also just happened while I was inpatient, but I gave the person like multiple different options. If you go in and stay a really long time, much longer than you think, then you'll probably taper off this injection. Is that okay with you? Yes, that's what I want to do. Okay. But when you get out, let's say you get out in a week or 2 weeks, I think, you should continue on this medication as it's life-saving and you've been doing well on it. Do you have a provider you could go to? Yes, I already have someone who's been prescribing me bupe for years. Okay, good. Or, okay, we started you on this medicine. You say you're so comfortable now. I'd love you to continue to think about continuing it after you get out of jail. Neither one of us knows when that's going to be, but there's XYZ clinic. On Fridays, if you walk into it, you can ask to see so-and-so, or tell them I sent you and that you need an appointment. Or, here's a more open access place. Or you say, listen, it's hard to get this in our community. Let's say you're in a community with less accessibility. Maybe if you know roughly when you're going to come home, have a family member or your girlfriend or somebody call and get you on the waiting list so that a spot opens up in the next, couple weeks or something. So you've helped somebody think through like what their different options are, given that everything's kind of up in the air a little bit. But I do think that that's the plan is never just getting them out of the hospital. It's like, you have to think of this real kind of transience they're going to have for a while. So it's getting them out of the hospital, into this other health system, and then back into the community health system.
And they
more
want you
like
to do
a
it all
leapfrog.
before 12 p.m. 12.
Yeah, or 11 a.m. Exactly. But I think those are really important things. And then the other thing is we have to like start holding all of our health systems accountable by communicating. Just because you don't know the people working in the local correctional health system doesn't mean they don't deserve a call with the plan, or to kind of push them to be involved in the plan. Hey, I'm sending you this guy. Here's the deal, with his permission. He's on this medicine. I don't know, but before he's released, can you help reinforce that he can walk into XYZ clinic when he gets out? So I think that we have to start breaking down these siloed health systems by ourselves taking the onus, too, of reaching in. We're always annoyed people don't reach out to us, right? But like we have to reach in to communicate these treatment plans and try to engage the health system inside in helping us connect people after release as well. They need to be a part of it.
This has been such a great conversation, Lisa. I feel much more empowered to help advocate for my patients, and I hope our listeners do too. Do you have any main take-home points?
Yeah, I think a couple. So I hope that everyone walks away understanding that mass incarceration is a uniquely American problem, and it's incredibly likely that you are treating patients who are impacted. If you don't know, you can't help. There are unique health risks that are addressable in primary care, in hospital settings, in all sorts of settings. And so if you can identify these risks, educate on the risks, and put in place a plan that acknowledges the person's intersection with the criminal legal system, I think you will find that these plans are more holistic, actually more engaged, and take better care of your patients. And then really addressing related issues and barriers to life after release due to the stigma of a criminal record requires building new systems of trust and engaging partners, and it really requires transforming the whole health system, but it pushes us to practice outside of our bounds and bring in team members to really, community members, et cetera, to really help. That's at the core of the whole transitions clinic model that I'm a part of, but I think we can think about that even in your average clinic.
Yeah, I love that. That's so great. And is there anything else like you want to related to this or not related to this that you want to plug that you think would be helpful to learn more about or just something you like or enjoy?
Sure. I'll plug maybe 3 things. One is Transitions Clinic. So the network is operated out of California. Our executive director is Shira Shavit. It is so special. Like, it is a national network of close to 50 programs all doing this work under their guidance. And it is so joyful. If this topic moves you, if you love taking care of people who have been impacted by the criminal legal system, think about a transitions clinic and check out their website. It's absolutely fantastic, and there's a lot of support to help us transform health systems. The other one is I'm part of a center here at Yale, the SAICHE Center for Health and Justice, SEICHE. We think of leveraging health systems to end mass incarceration through research, education, legal scholarship, and advocacy. And check out our stuff. We're often hosting some fun webinars and the such, and put informational, educational stuff up on our website as well. And then I know you had asked me about books I was reading. And so I always read like a couple books at one time because that's just like how I operate. I can't go straight through on anything. So I just finished A Song of Achilles. I love Greek mythology. It's a beautiful story about the Trojan War from a whole different standpoint. And then Heavy by Kiese Layman, who got a MacArthur this year. It is the most beautifully written prose I've read in a very long time. And it's probably the most enjoyable read I've had in years. So I really recommend that one as well.
Well, it's been so great having you, Lisa. Thanks again for coming on.
It's been so great being here with you. Thank you for highlighting this topic.
And we will be back with our lightning round.
Okay, Lisa, this is the lightning round, and we're going to ask you some rapid fire questions to get to know you a little bit better. So would you mind giving us a one-liner to describe yourself?
Hi, I'm Lisa Puglisi. I am a general internist to the core. I have a large extended family. That's really my foundation. I love preparing and sharing food with people I love. I love cultivating plants, and I love doing any activity that involves sun shining on my face.
I genuinely learned a lot about you just then, so thank you for that.
That was such a pleasant way to say I'd like to cultivate plants. It just sounds so warm and endearing.
And I guess tell us something that I'm always interested in is how you came to addiction med, because I feel like everybody's journey there is, especially since it's like not taught in medical school often, is so different.
Really circuitously, as with most things that I come to in my life, that just seems to be me. But I came to addiction medicine through incarceration health medicine and research. So I began working in the Transitions Clinic at Yale, which is part of, as you know, a broad national network of the Transitions Clinic network based out of California. And the whole focus is incarceration, the health needs of people coming home from incarceration. And through that work, I just realized I was totally ill-equipped to actually address the full breadth of people's needs. And so that work, which was my passion, demanded that I get better at this work, which has subsequently become a passion.
Yeah, I feel like that is probably pretty similar to a lot of people. I mean, that's the same how I felt being a hospitalist, and I'm sure same how I would guess a lot of people feel in all aspects of medicine, although I don't want to put words in people's mouths of feeling you got to be good at addiction med to be good at medicine in general, I hope.
Yeah.
And once you start doing it, you can't stop. It's so rewarding. It's so fulfilling. It's like you don't go back to not doing it. So we're glad to have you with us today. This has been another episode of our Curbsiders mini-series, The Curbsiders Addiction Med. Get your show notes at thecurbsiders.com/addiction.
We are committed to providing you with high-value, practice-changing knowledge, and to do that, we need your feedback. So subscribe, rate, review the show on Apple Podcasts, or contact us at curbsidersaddictionmed@gmail.com. As always, a special thanks to Dr. Matt Watto and Paul Williams for support, as well as ACAM, the American College of Academic Addiction Medicine. Learn more at acam.org. And a special thanks to our incredible team for this episode, including Associate Editor Dr. Sarah Leidy, and to our whole team. The Curbsiders is produced and edited by the team at Podpaste, who are the reason that we sound and look this good. And so until next time, I've been Sean Cohen.
And I'm Dr. Carolyn Jan. And as a quick reminder, you can still get CAP for this episode. It's curbsiders.bcuhealth.org. Just make an account. And thanks so much for joining us today and letting us bring you some addiction medicine pros.